surgically. Okay? Once you know the concept, everything is fine. In lectures, in my opinion, and this was the impression of the previous batches, is enough for the exam. Okay? If you want to read more about it here and there, it's okay, but don't read in depth for your level, because this is about management. I used to teach in embryology of these congenital diseases years ago. So this one is just about the management itself. Okay? So the first one we're going to talk about is the thyroglossus cyst. There won't be enough time for interaction, so I won't really waste the time. I'll just give you the concept and we'll move on. And the thyroglossus cyst is always understood in the context of the development of the thyroid gland. Thyroid gland usually develops with the development of the face and the mouth. It descends from the foramen cecum, which is like in the mid part of the tongue behind, between the 2/3, 1/3, and it goes down in front of the neck. Then it will diverge into both lobes connected by the isthmus for the thyroid. Within that track, something could remain, and that's where you get the thyroglossus remnant. Okay? And most of the time, it's a cyst. And it is and this is what I'm talking about. But this is not the exact thing that happens, because the baby is not formed when this happens. The face is having these branchial bodies and sinuses, and during that time, 5th, 6th week, that descent of the thyroid tissue comes down. And you see this part here? This is wrong. It goes through the bone, and that will have an implication of how to look at this disease. This is the way it looks. This is the thyroid, and this is the cyst. And how do they present? Most of the time, they come with a lump. And typically, they don't come at birth. Why? Small babies, they're always like this, so nobody really pays attention. And the neck is short. So when they grow up, you start seeing more of the neck. That's why we tell mothers to clean the babies, because they clean them, they give them a shower, but they forget this area. Not that it's important to detect it early, it's just so you know that it is there. And this is how it looks in a boy. They are here demonstrating the tongue thing. Now, it comes out with the protrusion, it moves. You know why? Because it's connected to the hyoid bone. Because the hyoid bone is attached also to the muscles of the tongue. That's why when the tongue moves out, it moves the hyoid bone, hence it moves the cyst. Most of the time, the cyst is sitting on the bone. That's why it moves with it. So problems, as I said, mostly incidental, but some of them they could present with an infection, becomes red, they treat it with antibiotics. Few of them will need drainage as an abscess. And that usually complicates the issue. Hypothyroidism could be a way of presentation. Why? Sometimes that tissue that comes from the foramen cecum does not go all the way down and form the thyroid. So this part is the only thyroid in the body of that child. Okay? And when they grow up, they need more thyroid hormone. So this tissue becomes hypertrophied. The size of it will be more prominent than they see it. So most of these cases, it's not a cyst. It's more of a tissue. But that's not enough to meet the needs for the body. That's why they could present with hypothyroidism. But this is really, really rare. And this is just an infected one treated with antibiotics. What could be there? Dermoid cyst could be a differential diagnosis. You find it at the same spot. A thyroid gland, as I mentioned. Lymphadenopathy, very rare to find lymph nodes in the midline, but I've seen it. And it was infected, treated with antibiotics, then disappeared completely. You do ultrasound, there is nothing. And sebaceous cyst could be, but most of the time in peripheral part of the body rather than the neck. And thyroid pathology, I'm talking about the part of the isthmus itself. If there is a cyst or a tumor there. Now, how to treat them? If it's infected, treat with antibiotics. You may have to drainage, but after that, you have to resect it. And the resection usually is done with something called cyst trunk. What does that mean? It means that you have to resect the central part of the hyoid bone with the cyst. If you don't, it will come back. You remember what I told you about the descent? It goes through the bone, and if you look at the bone, look, there are small connections to the major cyst. So if you cut it here, shave it of the bone, it will happen again. So you really have to cut it, cut that part of the bone, go towards the base of the trunk, and ligate it. This way, recurrence is almost zero. If you only take the cyst, the recurrence rate is high, 40%. Okay? Now, all what you need for the diagnosis is what? Ultrasound. To say this is cystic, and more important, to tell you that there is a thyroid tissue. Why do we have to know that? Because if the thyroid is not in its anatomical position, what's going to happen to this child when you resect this? Exactly. But nobody will notice. He will go for months being sick. Finally, somebody smart to say, oh, maybe his symptoms are related to the thyroid. But by that time, you already missed months of a patient with hypothyroidism. So if it is the only thyroid tissue, what will you do to it? If they do ultrasound, they say, oh, it's solid, or cystic but partly solid, and there is no thyroid here. What would be your recommendation? Leave it? No, but the thyroid now there's no thyroid, it's just this.
So you resect the
Still resect it, because it's really bad. I mean, first of all, patients, this is not enough. Second, cosmetically, it's not good. Just imagine somebody says, no, keep it, because this is your thyroid. Nobody cares. Take it, because thyroxine replacement is very simple, very cheap, available, and easy to replace. This is just how to look at it. This is the cyst attached to the bone. Now, genital lobar emphysema, when the lung starts developing, okay, it develops from the foregut. Goes with the trachea, then it will divide into the bronchus, then bronchioles, then airways. And the mesoderm will give the tissue, muscles, areolar tissue, the cushions. Okay? So around anywhere from the 12th to the 24th, that's where you have the major divisions of these airways. Something happens during that time which could form the cystic adenomatoid malformations and lobar emphysema. What does emphysema mean as a word? When someone says emphysema, what is it? No, but just emphysema linguistics. This is just air trapped somewhere. Okay? So if you say lobar emphysema, we're talking about air trapped in segment or a lobe. And simply what it is, air goes in with your negative pressure, inspiration is active. Your muscles, diaphragm, intercostals, create the negative pressure, the air goes in. Physiology, huh? But your expiration is mostly passive. Your diaphragm just goes back. It's not that you are saying, no, you don't do that. We don't do that. We just, and that's why the diaphragm works automatic, so you won't die when you're asleep. Okay? So, imagine that with negative pressure, air goes in, but then get trapped. Let's say you have a small segment of your lung. Let's say only 10% of the lung is emphysematous. What's going to happen to that 10%? Air in doesn't evacuate. Bigger. Then it crushes the rest of the lung and even the heart. So you'll have problems. Okay, so this is what happened to small babies. Of course, the severity of the disease is dependent on the type of the trapping. Now, why do they trap? Many things. Okay? Says here about intrinsic, extrinsic, this, that. You can read it. Okay? But most important, you have to understand, it's air trapping. Now, if the air is trapped, how can you save this baby?
Release.
So if it's an emergency, i.e. the patient is having troubles, they have to intubate, they have to take care of it, then you have to take them to the OR and resect it. Because this is the only way you can save them. If you're lucky, and it's only on one side, you can push the endotracheal tube into the other side. Intubation sometimes kills them. You know why?
Goes to the affected area.
Because you're giving more positive pressure, and that really can affect that. That's why when you take them to the OR and the emergency cases, the anesthetist has to be very careful not to give a lot of air. Wait till you open the chest, get it out, then he can do whatever he wants. Because that part is now outside the chest, it won't affect the rest of it. Sometimes it pushes even on the heart, and the heart will have what? Problems in filling with blood. So they will have diastolic cardiac arrest. So that's why you also ask them not to give a lot of fluids till you open the chest. I'm going to show you a photo now. See this? This is a case that I managed when I was in training. Look at this. Blackish, and look at this. This is called pulmonary herniation. The lung is pushing on the other side. Where is the heart? Here, somewhere. It's not here. So it's really pushed. There is mediastinal shift. Someone saw this case, thought it was differential diagnosis, pneumothorax. You know how to differentiate both? If you are looking at a lung tissue that's emphysematous, if you can't change the contrast, you will see blood vessels, white. But if it is pneumothorax, translucent, it's black. And if you're lucky, you will see the lung collapsed in the medial aspect of the hemithorax. So they put one chest tube, it didn't work. They put another one, it didn't work. So this patient was eventually intubated and sent to us. Then we ended up, this is the baby. Can you notice that the left hemithorax is bigger than the right side? Because babies, they have really soft bones. You can see it. And this is after we opened it. You see that? This is only a lobe of the lung. But the rest of the lung was really collapsed. Once you do this, the lung now will come towards the middle, like the mediastinum. The heart will be empty, they will be hypotensive, so the anesthetist has to be ready with the fluid right away, and they have to ventilate the rest of the lung. Once you do this one, it's curative. Now, something to be mentioned about emphysema. Sometimes they are diagnosed antenatally. And usually they don't tell you this is emphysema or something. They say there is a lung lesion. A lady who is in her 18th or 25th week of gestation, they do the ultrasound, they find something with the lung. Emphysemas, sometimes they improve, okay? They improve before term. By the 28th week, they start improving. So when they are born, they are really in good shape, and you don't have to do anything. You just have to follow them clinically. Some of the emphysema patients, they are asymptomatic at birth. You do chest X-ray, part of the lung is blackish, translucent more than the rest, but they are asymptomatic. What are the symptoms? Sometimes they say, oh, he's fine. But once you start feeding them, they start having shortness of breath. He's symptomatic. Sometimes they fail to thrive. Why? Because they cannot suck enough milk. Once they start sucking, because sucking is energy requiring activity, they feed short of breath, they stop. And they learn with time that feeding is no good for their lung. So they don't feed enough, so they don't gain weight. This is symptomatic. Those patients, you have to operate on them. But if they are asymptomatic, you wait, and whatever caused it, which is most probably bronchomalacia. Bronchomalacia, the bronchus itself is softer. If we go now back to this bronchomalacia, tracheomalacia thing, this is very important for you to know. A C of the cartilage is like this. This is the one in the front. And in the back is muscle. Imagine that the C is not a C. It's like that. During the expiration, the muscle will close the airway. And that's where it happens. When they grow up, around 1 year, the size becomes bigger, and the C will improve, and they are fine. So that's why some of the cases of emphysema, they improve, because that abnormality at the level of the bronchus improves. CCAM, on the other hand, is different. CCAM is a problem with the division of the airways. Okay? So those ones, they will never disappear. So those, you do antenatal, you find them, you follow the baby is asymptomatic. And they go home, they eat, they do everything, no problem. Then you come to follow up, you do another X-ray, it's still there. When you do the CT, you will find that there is part of the lung that's not aerated. It depends on the type. Some of them, they have big cysts. Some of them, they have small cysts. Some of them are solid. Okay? But they don't function. And risks of those two things. First, infection, most common. And the second one is cancer later on. Okay? Rhabdomyosarcoma usually develops in those. Or pleuroblastoma, which is also sarcoma. So you need to resect those. And you time it according to the size of the baby and your comfort levels. We do them now thoracoscopic. Some people, they want them to be 6 to 12 months before you go, because that will improve your chances of removing them with the thoracoscope. If you don't care, you want to do it open, just give them a chance 3-4 months. When they become good anesthesia risk, then you go ahead and do the resection. So this is what I'm talking about here. This is a baby newly born, and they did the CT. I usually don't do CT early on babies, just a chest X-ray, and then after that, when I'm ready for surgery, then I do the CT, just to demarcate it very well. And this is just to show you, this is fetal MRI, to show you the abnormality in the lung. I already spoke about this one. Differential here is bronchogenic cyst, mediastinal teratoma, congenital lobar emphysema, hemangioma, and bronchial atresia. Fetal things you don't need to know about them, this is just for your information. Okay, so this is about the non-GI. I just need the